No. Oh, all right. Welcome. Welcome back, guys. It's been a little while, I've been on vacation. I've been earning my keep here. They have me working hard. We're gonna move on to lecture number three, which if you're following in your own Who book at home, it is the fibrohistiocytic tumors, so-called fibrohistiocytic tumors. It's a small lecture, luckily, and I'm very happy to give it because it is hopefully going to be around 20, 30 minutes. So let's get started. Let me see if this is actually working. Here we go. Welcome everybody. Okay. All right. So, I have this slide at the beginning, but basically just a quick recap. Every single time we talk about line of differentiation, this is kind of the idea. We're really trying to nail down different areas, different lines of differentiation to narrow down the differential because it gets to be pretty unwieldy, as you guys probably remember from the fibroblastic tumors last time. So we're really going to focus on developing some criteria and just remember, not everything is a good example in this world. Actually, most of them are pretty bad examples. All right. So let's talk about the approach to fibrohistiocytic tumors. This is a little bit more straightforward, a little bit less complicated, I would say, than some of the other ones. As mercifully, it's a pretty small category of tumors, I would say. However, the morphologic features are pretty variable and dependent somewhat on the sort of the various admixtures of histiocytic lineage cells and fibroblastic lineage cells. So these tumors are generally, though, defined by the presence of a fibrous component or more of a spindle background component with some amount of prominent admixed cells of the histiocytic lineage. One thing that we really need to kind of nail down first is that histiocytes can kind of look whatever the fuck they want to look almost. They're just really weird at times. There's a couple of overlapping features that really help to note, but they can do a whole lot of different things. Um, Generally, the nuclear features and the cytoplasmic features have some overlap. So these cells generally have a lot of cytoplasm. So usually abundant, either eosinophilic to granular to cleared out cytoplasm, kind of foamy cytoplasm. And then the nuclear features are pretty characteristic as well. Generally, the nuclear contours are pretty irregular. They're kind of grooved and raisin-oid looking at times, just a little craggly looking. And the chromatin pattern is generally pretty delicate. That said, the nuclei can be quite big. You can get quite large nuclei as long as you have essentially abundant cytoplasm still. Or you can get very small nuclei and just like a bunch of foamy cells here. The cytoplasm can also be filled with a bunch of stuff. The histiocytes' jobs are to eat up everything in sight, so they're often full of junk, right? So, you might see some like anthracotic pigment, like in this lymph node here, or melanin pigment, and in these melanophages, right? So it's fairly typical to find stuff in there. So that's it's crucial to understand that like the cytoplasm is not always going to be very evident. It's sometimes will just be, whatever the stuff is that it's eating. All right. And then the other thing to note is that a lot of these histiocytic lesions, or fibrohistiocytic lesions, they also have a component of multinucleated giant cells. And we will say, by the way, this is kind of a really brief rundown. We will talk about histiocytic neoplasms further down the road when we talk about, Erdheim-Chester and Rosa-Dorfman and all that junk. That'll be its own lecture as it really entails its own lecture. So this is just a brief rundown. Giant cells as well, they tend to have a lot of different morphologies too. Yeah, that's true. We've seen a lot of weird histiocytic things lately, haven't we, Heather? Um, so like I said, multinucleated giant cells are a pretty prominent component of these tumors, but also a lot of other lesions, whether tumors or reactive things. And these are only some of the various types of giant cells that you might see in general practice. Do you guys know what some of these are? What's this one? They all have names and stuff, obviously. So, what this one might be called?
Osteoclast, like.
Yeah, it's osteoclast-like, or so-called. Sometimes people will call these foreign body giant cells, this kind of thing. So you'll see these pretty commonly obviously in the bone. They look like osteoclasts, or in foreign body. What about this guy?
Uh,
Wreath?
No, I
What's that?
think
Wreath. A wreath is kind of like a subtype. It's not really a wreath though, but
Mm.
is it Langhans cancer?
Langhans, right? Langhans, and it's not Langerhans, because Langerhans is a histiocytic tumor,
Mm.
but it's a Langhans
Langhorn.
giant cell essentially. So it has this sort of like U-shaped kind of horseshoe-shaped thing going on with this nuclei. What about this guy here?
Teuton?
Teuton, yeah, it's a Teuton giant cell. And so remember, they tend to kind of sit around the edge of the cytoplasm here, and then there's this surrounding foamy, sort of lipidized look outside. What about these guys on the right?
Laura.
Right.
Yeah, these are floret-like giant cells. So floret-like giant cells, they look like sort of like flowers, right? Usually you'll see them basically just sort of bulbous kind of nuclei towards the periphery of the cytoplasm extending out, just without the lipidized features. This one's a bit rarer. What do you guys think this one is on the left here? Anyone have any clue?
Looks like the cells you can see in reticulohistiocytoma and these kind of
Yeah,
lesions.
exactly. It's one of those weird where it's a very specific to a lesion. They're called reticulohistiocytoma giant cells. So they're notable because they're very oncocytic cytoplasm essentially. So you'll see that very nice oncocytic features. Those are kind of some of the smattering of giant cells you might see. All right. Okay, so let's get moving. Let's talk about these slides. Let's open this one first and get logged in and everything. Make sure everything is all settled over here on my side. All righty. This is educational. Perfect. Okay, we're gonna do this one. Okay, so let's get started. Here we go. Oops. Hold on. Let me hide that. Well, it's a label, so it doesn't actually matter. But let me hide that real quick. There we go. Okay. All right. So who wants to take this one? Let's see. We'll start kind of low power. All right.
I think I can start.
Yeah. Go for it, Mohammed.
I'm seeing just low cellularity is very pink at low power.
Okay.
Um, I'm
Mhm.
not sure what the organ is. I'm seeing some adipose tissue, some
Okay.
um,
Somewhere in the
fibrous.
adipose tissue, somewhere. Yeah. Okay.
Mhm.
Let's talk about the
Yeah,
borders of the lesion.
seems not infiltrated. Seems well circumscribed,
Okay.
if not encapsulated, but I'm not sure at this power.
Okay. Well circumscribed. All right. So let's
Yeah.
take a look a little bit higher power. What's that thing, by the way?
Sorry, I didn't see your mouse.
This one, this thing right here. What's this thing?
Oh yeah, that's the Pacinian corpuscle.
Yeah, just a little extra trivia. Just Pacinian.
Very pretty, very pretty.
Okay, cool. All right, what else?
Um, okay, so I'm seeing these sort of spindly slash histiocytic, fibrous histiocytic cells um,
All right. It's true.
that
It's true. We're in
have
that
abundant cytoplasm.
hmm
Yeah, exactly.
Yeah.
There's abundant cytoplasm, and they're not really forming any particular. They don't have any particular architecture that I can comment on. Some of them are kind of palisading in a way, but and
Okay.
then there's scattered giant cells as well.
All right. So not exactly a great architecture necessarily. You're just kind of seeing sheets of cells here and there. What do you notice pretty prominently in this area?
The giant cells, I mean,
Uh,
or
Not exactly. How prominent are the giant cells really?
I'm just saying I saw one or two. Like
There's a
there's a
couple. Yeah,
couple.
there's a
Yeah,
couple. What are you noticing kind
they're
of
not the most prominent.
outside of the cells themselves? What else do you see here?
I think
You know,
maybe are these prominent vessels or
I don't
I'm
see
not
a whole lot
sure.
of
Something
this.
eosinophilic that's going through.
Oh, you mean the material, like the amyloid amorphous type
Well,
like
there's something
material.
in the background, right? It's not exactly amyloid, that's true, but there is this kind of pinkish stuff going on in the background. So remember, you got to comment on the stroma as well. That's really helpful to think about stroma.
Right.
Okay, so what do you think about the stroma?
I mean, it's hyalinized or fibrotic.
Okay, perfect. Hyalinized, fibrotic. Okay, so there's a lot of fibrosis. All right. Now let's take a look at the cytology up close. We'll look at some of these cells first. How would you describe these?
It's bland. They have very little pleomorphism. The nuclear cytoplasmic ratio is low. They have
Okay.
epithelioid uh, morphology.
Okay.
Um,
Thinking about epithelioid. Okay. All right. Anything else?
uh,
Any other words you might use?
Are these reniform? They look
Uh,
kind of crunched.
There's a few, right? But think back to kind of what we just talked about with the concept of histiocytes, right? So they have a
Oh,
lot of
right,
different
right.
looks, right? So this is in essence histiocytoid morphology, right? So
yeah,
abundant eosinophilic cytoplasm, and then exactly what Lacey's talking about is that you have this sort of like misshapen contours and stuff. So and very delicate chromatin pattern, very typical of histiocytes or histiocytic lineage type cells.
yeah.
Cool.
Some have very prominent nucleoli too, like a single prominent nucleolus.
I will say I agree that there's nucleoli. I would say it's probably not that prominent. I would feel like I'm just kind of shitting on everything you're saying, but just
No, they
uh
need to be bigger to be
just to
prominent
be
if they are
clear,
obvious.
we love to say prominent nucleoli sometimes, but just when we see it, your eyes are good, as a pathology resident, you got really good eyes, so you can notice this, but it needs to be prominent to maybe it needs to be prominent to a surgical resident. How about that? That's a gen surg resident.
Yeah, I'd call it inconspicuous. My
Yeah,
favorite word.
they're sort of like they're inconspicuous,
I mean,
even
they're there, but they're not like melanoma.
they're not huge, right?
Yeah,
So nucleoli are pretty typical in a lot of cells that you see.
that exist.
Yeah, so including histiocytes, it's often you'll see a little nucleolus right there, here and there. And that's okay. That's all right. What about over here? What's this?
There's like a mite.
Yeah, there's a
Interface.
mite. There's another one right there.
Mhm.
All righty. Okay. And then there's another one right there. Look at that. Wow. All right. So what else did you notice? You noticed the giant cells you were talking about? Let's go find where those guys are. They
Okay.
were over here somewhere once this loads up. There we go. All right. What do you think about these?
Mm.
How would you describe the giant cells?
Osteoclast-like
Uh,
or
Yeah, they're kind of like
foraminifera-like.
Plasmic, yeah.
osteoclasts, like giant cells, right? They just have this evenly distributed nuclei, right? And how would you describe the nuclei?
I mean, they're small, they're homogeneous. They don't, there's not great pleomorphism.
Okay. Does it look like the background? Is
Yeah,
like
I think so.
these nuclei look like these guys? Yeah, pretty much, right?
Yeah.
So that's kind of typical, right? All right. So let's come back out. Let's talk about benignancy, malignancy. What do you think?
Uh, Probably malignant.
Malignant,
Sorry, probably neoplastic is what I meant to say,
neoplastic. I agree. Neoplastic. All right.
and
And
probably
yeah,
benign.
probably benign. Do you have a thought what this could be?
Um, it's not a dermatofibroma, just given the location, but could be like a, I don't know, tenosynovial giant cell tumor or giant cell
Sure.
tumor of soft tissue, something like that.
There certainly could be. Okay, so we're in that spectrum of things, right? We're wondering about, giant cell tumors and the like, right? Because there is a giant cell component
Mhm.
to this. So that's
Right.
important. Okay, and what are these guys here?
Mm,
Anyone? Feel free to anyone.
Yeah, foamy histiocyte.
Yeah, foamy
yeah.
histiocytes or lipid-laden macrophages. That's pretty common in this lesion as well. And so I think we saw some out here. What's this? Some
Histiocytic.
Yeah, exactly. Get some immunohistochemical. So we have some number of classic features here. So fibrotic areas throughout this, including large fibrotic bands, right? Which you can see right here. So a big fibrotic banding. You have mononuclear cell histiocytoid proliferation, and then you got scattered giant cells, right? So all that put together, you did say it. It's true. It is a tenosynovial giant cell tumor, and we'll talk about what the deal is between tenosynovial giant cell tumor and giant cell tumor of soft tissue, like you said before, because the two are distinguishable on histology. So, and that's kind of a crucial distinction to make. All right, cool. Before we move on, any questions about this? All right, I think we might have some additional. Yeah, we do. Okay,
Ooh.
we do have some ideas here. One second. Here's another example, just to kind of show you another example of one. So, and you do see it can be quite cellular, right? But there is an extensive amount of fibrosis that runs between, and you can see a number of sort of these mononuclear cells and a lot of different types of giant cells here and there. Just another example right here. All righty, and then what's going on here? What is this thing? So let's take a look at this one. So you see that there's this architecturally, what do you say?
Oh, like fronds or
Yeah, it's kind of like fronds, almost like a villus architecture, right?
yeah.
Yeah.
Yeah, that's right. But when you look in the background here, you have the same features as what you were seeing in the other one, right? And this one may have some more lipid-laden macrophages probably, and maybe more hemosiderin, but but overall you still have this mononuclear kind of histiocytoid proliferation, right? And then
Yeah.
you'll have scattered giant cells throughout. Okay. So what would you call this one?
Cellular Tenosynovial giant cell tumor.
Cellular? No, not really. Not really. It can be normal. They can be the cellular. No worries there.
Maybe this is the diffuse type.
Yeah, exactly. Right. So the question, and this is often not something you see histologically in terms of making that distinction histologically, but we know this is kind of emitting sort of a villus architecture into the joint space.
Mm,
So
mm.
it's typical
Chronicity. Mm.
of the diffuse type. We'll talk about the two in a moment. But yeah, does anybody know sort of the old terminology for this?
Yes, as Heather pointed out, pigmented villonodular synovitis.
Perfect, she did. Yeah, so PVNS, pigmented villonodular synovitis, which is basically just the wrong word to use now. So you're forbidden from using
It's just wrong.
now that you've gotten it out of your system, you've all said it. Pigmented villonodular synovitis. It's wrong. It's not. We don't use it. But it kind of goes to show you yeah, I guess exactly what Heather's saying. The reason is that it's not an inflammatory condition. It's not like a synovitis. It's actually a neoplasm. It's tenosynovial giant cell tumor, right? So it's a neoplasm. But it kind of goes to show like, oh, okay, very villous looking architecture, and it's generally pigmented, a lot of hemosiderin. So they see that grossly in the joint. Um, so it almost looks like like a rheumatoid arthritis, or like some sort of synovitis or chronic synovitis. But it's really a tumor. All right, perfect. Okay, great job, guys. Let's move on here. Okay, so tenosynovial giant cell tumor, also called giant cell tumor of tendon sheath, right? So, like I said, these things can be things can be diffuse or localized, right? The diffuse type we just looked at, the first one was a localized type, meaning it's generally a well-circumscribed nodule. And these can generally they're intra-articular, but a subset of them can actually be extra-articular. So they can actually be outside the joint space, often in like the muscle around the joint space. That does happen. The majority, about like 85%, are in your fingers, but they can happen in larger joints too, like the knee is pretty common. And your tumors that occur in your fingers tend to be localized more commonly. So pretty wide age range, usually around 30s to 50s, basically. But the diffuse tumors, they often happen in younger patients. So for whatever reason, they're kind of worse tumors to begin with, and they happen in younger patients. So, It's just screwing all the younger kids, I guess. So these tumors are benign. It's true. They do have local recurrence potential, even the localized types, but the diffuse type tumors generally have a much higher risk for local recurrence. The reason it's actually really just hard to get it out of the joint, basically. It's hard to remove it all. So, they'll try their best, but they often recur about like 40 to 60% of the time. And the problem is that over time, these things can essentially destroy the joint. They can even lead to amputations in the end, essentially. They'll lead to joint reconstruction. So they can be very morbid, depending on how it's treated, right? So it's not a great tumor to have generally. There are some targeted therapies, right? Since pexidartinib is the main one that people use. It's kind of the first line. So medical therapies can help, and we'll talk about why that works. Um, and this is one of those tumors that can rarely have these sort of like benign implants or metastasis to lungs or lymph nodes. So that does happen. So don't let it freak you out. You can get malignant transformation in these, but it's extremely rare. So I wouldn't really stress about it too much. It just doesn't happen all that often. So going back to our histologic criteria, things you need, right? So the things that you kind of are required. You have mononuclear histiocytic cells; those are required, right? You need sort of this background fibrotic tissue. So the fibrosis in the background, that's kind of required. And then at least focally, right? But generally you'll see larger fibrotic bands. And then multinuclear giant cells. And they can actually be pretty sparse. Sometimes you can kind of suggest it if you have like a small biopsy and don't technically see giant cells. The stroma and those histiocytoid cells still look pretty characteristic. But if you look around, you should see like one or two here or there. The additional stuff that's not necessarily required. The lipid-laden macrophages, the hemosiderin, where it's located, that's not really a requirement for the diagnosis. There are some IHC you can do. It's not that helpful generally. If any sort of histiocyte marker will be positive in all these. Clusterin is actually a marker of synovial cells, right? Synoviocytes. So you do actually get clusterin positivity in these tumors. You don't really do it all that often either. It's important to know it kind of rarely you can get Desmond positivity as well. All right. So the molecular, it's usually a rearrangement in CSF1, which is involved in the CSF1 pathway essentially with CSF1 receptor. And so pexidartinib is actually a CSF1 receptor inhibitor. So that's how that works. Not everything on this list, actually. In fact, everything else on this list is generally not going to have a CSF1 rearrangement, but will fall somewhat in that differential with tenosynovial giant cell tumor. So if you are able to tell them, hey, it's diffuse type TGCT or TGCT in general, that opens up a whole lot of options to them, or it opens up a very big option to them for medical therapy. So whereas it doesn't with other things like giant cell tumor of soft tissue, for example. All right. So crucial thing that whenever you look at these, you always need to look at the radiology to really detail the difference here between the diffuse and the localized type. If you can, I would comment on whether you feel like it's diffuse or localized. If you're not able to, you don't have the radiology or it's not clear, your radiologist is not giving you a straightforward answer, you can always just say like correlate with radiology, sure, because that's important. But the diffuse type is just some helpful features you can look at is the diffuse type tends to be more common in larger joints, usually the knee is most common spot. Localized type is more common in smaller joints. You can have either in either type, but it's more common to see one way or the other. Both of these can actually have some areas of cortical erosion, so you can actually get a little bit of erosion of the underlying cortex of nearby bone. And ultimately, you want to correlate with radiology. And so you can see sort of on the left here, this is an example of a diffuse type TGCT that's pretty exuberant. So you can see essentially it's just throughout the entire joint, essentially. So somewhat ill-defined mass extending throughout the joint space, as opposed to a localized type, which is going to be a pretty well-defined mass arising off the tendon. So, makes sense? Sweet. All right, moving on. Next up, next slide, I think is this one over here. I've already got it open. Oops. There we go. All right, so this one comes courtesy of a different of a different website, but we'll take a look at this one. All right, so location,
Again,
it is in the skin. All right, so what are we looking at here? Let's talk about borders first.
yeah, it looks like a dermal lesion. I don't see any connection to the overlying epidermis.
Okay, dermal
It's
lesion, no
Yep,
connection to epidermis. Good.
yep. The margin or the borders are well circumscribed for the most part, but I do see some areas that are kind of trying to be into the infiltrating borders in some areas.
Okay, so it's somewhat ill-defined borders, right? And what
Yeah,
do you see on the edge here? What's standing out a lot to you right here?
yeah. I see
What
a
is
lot of collagen trapping between these
Oh,
cells.
trapping? Exactly. That's kind of the word to use, right? So this all this stuff is dermal collagen, right?
Mhm.
So you have this sort of trapping of the dermal collagen around the periphery of this lesion. Okay.
Yeah.
All right, and let's talk about the cytology here.
Yeah, it looks like a histiocytic lesion. And the reason I say this is because they have these kind of elongated nuclei with this foamy, pale cytoplasm.
Mhm. Yeah. Okay, so there's kind of like some foamy cytoplasm. That's true. And it seems to be somewhat of an admixture of cells, right?
Yeah.
So you have more histiocytoid cells, and more some scattered spindle cells throughout as well.
Yep.
So, okay, all right. I think we won't belabor the idea. What do you think this is?
Dermatofibroma.
Yeah, it's a dermatofibroma. So, the dermatopathologist's best friend.
right.
I know. Also called benign fibrous histiocytoma, or just nowadays fibrous histiocytoma. But we'll get into that. Okay, I think that's everything I have there for that one. All right, so BFH or fibrous histiocytomas, they have pretty wide age range. It can really kind of occur in a lot of different patients. Most commonly, kind of starts around their 20s and 30s. It has a nice, generally a dome-shaped appearance and kind of dusky brown skin nodule usually when it's a dermal example. Sometimes they can have more erythematous look or sort of the central dimpling that can happen as well. And the key thing here to know is that these things have like a billion different histologic subtypes, and most of them are completely irrelevant. Even though we have probably 70 years of literature detailing a million different types. So the only ones that are actually, worth anything are the atypical variant, the aneurysmal variant, and the cellular variants, really. Also the epithelioid variant, but I kind of see that as a different tumor, to be honest, because it's its own thing. Um, and then so there's a lot of different other types that are all clinically insignificant. Granular cell type, collagenous, lipidized, ankle type or whatever. Um, these things are all the same as regular dermatofibromas, basically. These tumors are benign. They do have relatively low risk of local recurrence, but the reason that we actually care about the other ones, the atypical, the aneurysmal, and the cellular, is that they have a bit of a higher recurrence rate, around 20%. Rarely they do metastasize. You will see fibrocystiocytomas occasionally met. Sometimes the lung, sort of like implants again. It's a low grade met still, which is why they kind of started to remove the benign from the name. But usually it tends to be like the cellular variant, or examples that are kind of deeper, like deep fibrous histiocytomas. Those tend to be more common. All right. So the criteria here. So the major thing that you generally you're going to see is either fascicular or a story forming kind of whorling growth. I actually tend to see that quite often. This one that we looked at didn't have super great example of story forming, but most dermatofibromas tend to be very story form kind of whorling look, right? Which is important because we talked about last time that DFSP is very classically story form tumor, and the major differential with DFSP is fibrous histiocytoma. So Most superficial tumors, they tend to have that ill-defined collagen trapping. That's a good histologic criteria. Deep tumors, or deep fibrous histiocytomas, they tend to actually be more well circumscribed for whatever reason. And then you'll see a mixture of histiocytoid cells and spindle cells. That's what you need. The additional features, it's variable, right? Depending on the type, right? Depending on the subtype. Other useful features that these sort of more cutaneous tumors can have overlying epidermal hyperplasia, which can be a useful thing to look for. All right, so stains. To be honest, I find stains not that useful for fibrocystiocytoma. Um, I know our dermatopathologists like the factor 13. It's kind of an annoying stain to interpret, but generally, these will be positive for, histiocyte markers and factor 13, and usually negative for 34. Deep fibrous histiocytomas, though, tend to be positive for CD34 more often. And then SMA and Desmond are actually pretty commonly positive in fibrous histiocytoma, so just don't get fooled by that. Would think like thinking Lyo or something. Okay, so molecular is usually not required in any way, but there can be recurrent gene fusions in PRK, PRKCA, B or D. The important thing is that they don't have COL1A1 fusions, right? So that's what differentiates it from DFSP. And you can use the fusion if you want. Generally, the more story-forming architecture, the septal infiltration, and the more monomorphic cells, right? The lack of histiocytic differentiation can kind of really be enough to differentiate the two. But you can use the fusion if you want. All right. Let's see. Here's some examples of some variants, obviously, because we have to show them. They worked so hard to describe these. So, but anyways, on the bottom left, you got the atypical variant, which you just see more atypical cells scattered about. This is the aneurysmal variant, the big blood-filled lakes, pretty typical. And it's an aneurysm, sure. This one's called the hemosiderotic variant, because I don't know, is this hemosiderin in there? This is an example of the epithelioid variant here, which, like I think, to be honest, it's not quite a variant. I'm not going to talk about it in this lecture, really. It's kind of more newly described. And those tumors are often ALK rearranged. So I kind of think about
Mm,
it as its own tumor almost. But yeah, you can see how it's very epithelioid looking.
yeah.
I think here's another example from my own archives of the ankle type.
Oh.
This is the lipidized variant. And so you can see they tend to be very lipidized, and they often have this like sclerotic kind of sclerotic
Mm,
fibers running through, almost keloidal.
mm,
So that's pretty typical with ankle type. Yeah, whatever it is. The one thing I would say that we do need to make sure you guys understand is cellular fibrous histiocytoma. So I'll pull that open right now. Here's an example of one. I've seen a few here and there. I just didn't have that many examples of these, but cellular fibrous histiocytomas are one of these weird tumors that they can really scare a lot. They can really scare people for high-grade sarcoma. So I've had cellular fibrous histiocytomas that we called CFH. One institution called low-grade sarcoma, another institution called intermediate-grade sarcoma, and another institution called high-grade sarcoma. So it really is like a weird sort of issue that happens with concordance with these. I tend to think about these in the vein of Dr. Fletcher, who has unfortunately passed away. But he wrote sort of the initial like major papers on cellular fibrocystiocytoma, and I trust his ideas on that. But generally, they will tend to, rather than just having a sort of whirling architecture, you'll often start to see a lot more fascicular architecture. People do wonder about fibrosarcomatous DFSP when these cases happen. I think what's helpful to see is if you see a lot of mitotic activity and you see a lot of like areas of necrosis even, you see mitotic activity, you see, a very sort of dense cellular infiltrate, cellular spindle cell tumor, I would sort of hesitate to jump to DFSP. Even fibrosarcomatous DFSP doesn't often have that many mitotic figures, but you really want to consider that. This one still may have this one's actually metastatic to the lung, but it is kind of a difficult tumor to diagnose sometimes. And what really helps here is having some molecular as well, just to make sure you're not missing something like some sort of other spindle cell sarcoma. But um, it does occasionally help to see some background histiocytic differentiation. This one still has some giant cells here and there as well. Cellular fibrous histiocytomas are important to note because they do have a higher recurrence risk, but generally with complete excision, they do well. Cool. Any questions about CFH? It's kind of a weird tumor, honestly. It's a little bit of a tough one.
What was the molecular for the uh tri-institutional disagreement?
That one I don't think we did molecular on it,
I
but
see.
we were right because we're always right. But everybody has their own opinions, I'm sure. But anyways,
And
uh,
then for deep
yeah.
fibrous histiocytoma, is it just a dermatofibroma that is deep?
Yeah,
Okay.
yeah. So deep down into the generally subcute. So you'll see a little well circulated ball of FH down below. So, all right, perfect. That is that one. Let me see what's our next slide here. Okay, next one. I don't have a slide for it, but I do have an image, and I just wanted to ask you guys, what architecture is this?
Plexiform, yeah.
What's that? Sorry.
Kind of plexiform.
Yeah, Plexiform. Yeah, exactly. So you see these little cannonballs here, basically, of tumor. This is a Plexiform architecture. So what happens to be Plexiform? Do you guys know? What tumors are Plexiform?
Plexiform fibrohistiocytic tumor.
Okay, that's true. That's what happens to be in your WHO book. Thank you. Thank you. Anything else?
I mean, you can have plexiform neurofibroma, you can have plexiform
True.
schwannoma, you can have,
True. That's true.
yeah.
You can also, yeah. Plexiform neurofibromas and schwannomas can occasionally be plexiform. What else?
I think gas, autonomous soft tissue, you can have some areas of plexiform architecture.
Maybe. I don't know about that. How about dermal nerve sheath myxomas can occasionally be plexiform, and then cellular neurotheciomas can be plexiform. So there's just a number of random tumors here and there. So it's important, I think, you guys get the gist of what the hell plexiform even means. This is not my picture; it's from Pathology. So credit to I think Dr. Daner at Pathology for this. Okay, so uh, but what we do notice here is that there's this kind of like nodules of histiocytoid cells with giant cells and intervening kind of fibrous stromal tissue, right? So that's exactly what describes at least one look for plexiform fibrohistiocytic tumor. The reason why we don't talk about this tumor a whole lot is because it happens in kids, and everything that happens in kids, we don't talk about here. We'll talk about it later. But anyways, it's usually in younger patients, and it tends to be dermal subq, kind of often on that dermal subq junction, actually. Um, these tumors are kind of canonically not actually benign. They're one of these like locally recurrent, rarely metastasizing tumors. So in the intermediate category, right? So they have a pretty significant risk for local recurrence, around like, they quote like 12-ish to 37%. And they rarely metastasize and usually to lymph nodes. Actually, they do often have LVI. They present like 20% of the time with LVI. So that's a noted thing. So histologic criteria. Plexiform architecture is the main thing. You gotta have it, right? It's generally sub-Q slash dermal, right? So those are kind of what you're looking for. And then the other criteria depends on which variant you're looking at. There's three general subtypes of what it might look like, right? So one is the fibroblastic variant, one's the histiocytic variant, and one's the mixed variant. What we just looked at is the histiocytic variant, where you see these nodules of histiocytes and more of a scar-like fibrous background throughout. Um, the fibroblastic variant tends to be much more, almost more like fibromatosis in the background, much more cellular spindled background, with still those plexiform nodules in there that happen to be there. Sorry, I said mixed. The one we just looked at is the mixed variant. Sorry. The histiocytic variant tends to be much more like just, plexiform nodules of histiocytes, right? So anyways, the tumor generally has a biphasic morphology overall, and it's some varying amount of those features. That fibroblastic myofibroblastic background, and then the nodules of histiocytoid cells. The fibroblastic background, even though I've been saying fibroblastic, they are kind of more myofibroblastic differentiation. So these lesions often stain with SMA in the background. And the histiocytic cells will stain with histiocyte markers, of course. You may have some areas of hemohemorrhage, hemosiderin inflammation, all that's possible and not that important. Cool. All right. Any questions about plexiform fibrohistiocytic tumor? The answer is, by the way, we do not have any known really molecular about these. So I don't have any information there, even though you know me, I love talking about the molecular. Nothing there. Cool. Sweet. Next up, got digital slide 3. And somehow I've turned this into an hour-long affair still. But that's life, you know. All right, so what are we talking about with this? Okay, so let's move in here and let's take a look at this lesion. And who wants to describe what they're seeing?
So many more giant cells in
Lots of
the other
giant cells,
cases.
right?
Yeah.
There's a whole bunch of giant cells, a whole bunch of like osteoclastic giant cells, pretty much. So
Yeah.
it's a very cellularly dense tumor. And you can kind of see right here, there is a background, right? It's not all
Oh,
giant cells, right? So
yeah.
there are some
Mhm.
intervening, right? So just to cut to the chase, what do you think this is? Let's say we were in the bone. What would you call it?
Giant cell tumor of bone?
Right, a giant cell tumor of bone, right? Exactly. So, I mean, you have this high density of giant cells here. Um, and essentially hypercellular areas of giant cells, but also the giant cells tend to have a lot of nuclei within them, so they tend to be hypernucleated, right? And then you still have the background mononuclear cells, right? So if I were to say this is in bone, you would think giant cell tumor of bone. All right, well, it's in the soft tissue, so giant cell tumor of soft tissue, right? Okay, so giant cell tumors of soft tissue essentially look pretty much exactly like giant cell tumors of bone, but they just happen to be in the soft tissue. They are different tumors, of course, which we'll talk about. The key features here, the key thing to know, this was actually the differential. This was somewhere in the hand, and the differential was, is this tenosynovial giant cell tumor or is it giant cell tumor of soft tissue? Giant cell tumors of soft tissue can behave worse than TGCT, like localized TGCTs. So it's important to make that distinction. And there are some areas of collagenous banding running through here. But it's almost more like pseudocapsule. It's almost more like capsular tissue. It's weirdly enough. But when you go into the actual nodules, there's really very little fibrosis, right? So the lack of fibrosis throughout here, the heavy density of giant cells, and the more nuclei within the giant cells, making it look like giant cell tumor of bone, essentially helps that distinction between giant cell tumor of soft tissue and tenosynovial giant cell tumor. And and Heather is completely correct. Yes. So exactly, giant cell tumor of soft tissue. And yeah, these don't have the same mutations as giant cell tumor of bone. So even though they look the same. All right. Okay. Let's do I have anything else? No, I don't. Okay, so let's move on to the info slide and we'll go into further detail. So giant cell tumor of soft tissues, they're most often in the extremities, usually pretty superficially located. And they have pretty wide age range, like we said before. Morphologically, they are similar to giant cell tumor of bone, like I said, and they do have a local recurrence rate and can metastasize. As you've kind of felt from all these things that we've talked about, they all have this weird sort of, all these fibrohistiocytic tumors have this weird sort of propensity to have rare mets, right? So that is kind of an overlapping feature with this whole group. So here's your histological criteria. It's a cellular histiocytoid mononuclear cell proliferation with very dense osteoclast-like giant cells that tend to be much more dense than TGCT. Okay, you can get a lot of additional features. Giant cell tumors in general, giant cell tumors of bone and soft tissue, they can look very strange at times. You can see necrosis occasionally. You'll see a lot of mitotic activity sometimes. Hemosiderin, lipid-laden macrophages, hemorrhage, cystic change, metaplastic bone formation, spindling, tumor cell spindling. So they can get really funky. The important thing to note is that these things don't have, as Heather said, they don't have the mutations in H3F3A, right? And they also don't have rearrangements of CSF1. It's not clear if they have any relevant recurrent genetics, to be honest. So that helps distinguish between these two if the question is there. Cool. All right. Any questions? Any thoughts about
Yeah,
GCT?
I have a thought and a question
Yeah,
or a comment.
go for it.
So from that image, it looked like really kind of bloody, like extravasated red blood cells. Is that generally how they appear in your
Very
experience?
common. Yeah, it's very common to see hemorrhage,
Mm.
right? It's very common to see hemorrhage in general, but then also a number of, particularly in the bone, like giant cell tumors of bone, you can often get aneurysmal bone cyst changes, ABC-like changes that cause a lot of
Mm.
hemorrhage as well. But I would say it's very common. Most GCTs have a lot of hemorrhage.
Yeah, but the degree of like bloodiness in this last specimen, I feel like didn't really match the degree of hemosiderin laden macrophages, and that makes me feel some sort of way.
Trying to blood shame this tumor?
Yeah, I think so. But
It's
it's nothing, it's
got
fine.
plenty
It's
of blood, That's true. I mean,
yeah,
so it does it will have a hemosiderin, right? But it takes time for the blood products
right.
to turn into hemosiderin. So yeah, you'll
Okay.
see kind
Okay.
of mixed pictures of both. Some of it obviously could be procedural if you're trying to blame the surgeon for
Yeah, kind of.
a bloody mess. That can also be the case.
Okay.
That's
Thanks.
true. That's true. All right, perfect. Okay, moving on. We have one final case that's just more of a fun one, and then we
Mm,
will call it a day.
sure.
I forgot we need to open my cell sense because this is a glass slide. So give me a second to pull that open.
Go get your dusty
box.
box.
Glass slide.
His
Yeah,
glass
right.
slide. He told me today he doesn't even do glass slides anymore.
I know. Glass slide. Your glass slides are from the
From the
Paleolithic era.
40s.
We're cavemen still over
Yep.
here. All
Yep.
right, give me 1 second. Cell sense usually takes 3 hours to open. Okey doke. All right. As soon as you hear the loud noise, that means it's ready.
Booting up.
There we go. All right, let's take a look. Okay, so, all right. So who wants to look at this who wants to think about this one first? Why don't we talk about the borders? First of all, I guess kind of superficial, maybe sub-Q.
Hmm.
Yeah, it
All
looks
right,
like
maybe.
it's the sub-Q.
Okay, what do you think at the borders?
Well circumscribed
Well, sir.
borders.
Yeah, agreed. All right, if we go in now, we'll take a look at what's happening in here.
Hmm.
So architecturally, just kind of a lot of sheets, right?
Yeah, sheets of cells, scattered, giant cells, a lot of mononuclear cells as well.
Mhm. Okay. Giant cells, mononuclear cells, hemosiderin.
Hmm.
Yeah, that's true. That's true. Some lipidized cells, of course, in the background. Okay. A lot of inflammation too, some plasma cells for whatever reason. Okay.
Yeah.
Interesting, interesting. So, what is your thought?
And my first thought when I saw this, I was thinking, like, is there a giant cell tumor of soft tissue?
Yeah.
Because we do have osteoclast-like giant cells. We have mononuclear cells. The nuclei of the mononuclear cells, they look similar to the nuclei in the osteoclast-like giant cell.
Yeah.
We do have some hemorrhage in some areas, and we do have some hemosiderin-laden macrophages as well.
Yeah, that's pretty cellular. It's not exactly showing huge fibrotic banding anywhere necessarily. It does kind of fit somewhat a little closer to giant cell tumor of soft tissue. Weirdly, a lot of plasma cell inflammation in here. I'm not sure why necessarily,
Hmm.
but okay. But the other differential would be something like Tenosynovial giant cell
Hmm.
tumor.
Yeah.
Yeah. All right. So this is an interesting case here. It's just a little like unassuming. And if you called it some sort of giant cell tumor, nobody would be the wiser probably. And that's totally fine. Um, let me show you. Here's the CD163. Unsurprising, right? Lots of 163.
Yeah.
Histiocytes everywhere, certainly. Okay, let me show you one other thing.
Uh-oh.
Mm.
Oh,
I'll show you the control first.
yeah.
Here's control. What is this control? What do you think? Is this
Keratin.
it's like an invasive ductal carcinoma or something?
Yeah.
All righty.
Yes.
What's going on here?
Some keratin positivity in the background.
Yeah,
It's like
there's a lot of keratin
perinuclear.
positivity in here. That's interesting. So there's a lot of keratin positive cells in this lesion. What's that mean?
Oh,
That's weird. Does anyone know what we're working towards here?
Bien epithelioid sarcoma.
Epithelioid sarcoma, could consider that for certain, right? Could really think about that. The background, not particularly right? But when you think about it's missing either for the classic type or distal type, it's missing the pseudogranulomatous sort of geographic necrosis, right? If you're wondering about could this be more like proximal type, and that tends to be more sheets of epithelial cells, but you don't really see giant cells, right? So you might wonder about that though. It's like, why are there so many keratin positive cells in here?
hmm.
And this actually happens to be an interesting tumor that's its sort of own tumor that kind of falls into these giant cell lesions, right? Aptly named keratin positive giant cell tumor.
Shut up.
Yeah.
So it's not epithelial giant cell tumor.
It's
Could be. Maybe it's a new name for it. Here we go.
photokeratin
These are
giant.
called, these we kind of call these days keratin positive giant cell rich tumor of soft tissue. And some other studies have called them xanthogranulomatous epithelial tumors, and they may have various amounts of more xanthogranulomatous appearance or more giant cell tumor soft tissue appearance, right? So there's these various entities that have been described that are probably all in the same spectrum, right? So they have overlapping features generally, but their positivity for pankeratin is pretty consistent, and they have an underlying gene fusion that helps, right? So just a little fun thing. It's not super important to recognize, but they do have generally good prognosis, but they can have pretty variable recurrence risk and maybe relatively high recurrence risk in some studies. And I think Mets have been described. I can't remember. But yeah, so it's if you do happen to notice it, yeah, you'd want to mention it, but it's not hugely different, right? And these generally don't have CSF1 alterations, but they actually may respond to pexidartinib, right? Because the fusion actually relates to the CSF1 pathway, so they may actually be amenable to therapy if that's an issue, right? So histologically, they often have similar morphologic features to giant cell tumors or xanthogranulomas, right? You may maybe see more Teuton giant cells and a lot of xanthomatous cells, right? And they pretty consistently have IHC for pankeratin. The molecular that's been found that's sort of underpinning this is an HMGA2 fusion, generally with N-core2, not N-CoA, but N-core2. So, but they're HMGA2 fused. So, just a little fun thing. Obviously, you don't need to remember this, but it's just a little cute case, and I thought I'd have it. All right, I think that happens to be everything. All right, guys, we've gone 20 minutes over time, and I'm now actually need to go break my fast. So, so long.
So long. Thank you.
Thank you so much.
You.
Bye.